disabled for all participants. And so with that, I would like to introduce our first speaker. Our first speaker is Dr. Imran Ali from York University, Toronto, Canada. You can start sharing your slides now. Thank you.
So test one, can you hear me okay?
Can hear you and see you.
Test two, slides, okay, great. So waterborne illnesses are among the leading causes of preventable mortality and morbidity among displaced people during humanitarian emergencies. Safe water is essential for protecting public health, and we as humanitarian responders have technical guidelines to help us deliver safe water to people. But do they work, and could we do better? I want to dive into this question today and tell you a bit about some of the work that we're doing to help ensure that water is safe to drink and public health is protected during humanitarian emergencies. I'm presenting this work on behalf of an amazing group of collaborators at the Dahdaleh Institute for Global Health Research at York University and at MSF Doctors Without Borders. Let me tell you first a bit about the motivation for this research. Back in 2013, I was working as a water and sanitation specialist with MSF during a major refugee crisis in South Sudan. These camps in South Sudan were overwhelmed, underserviced, and faced multiple outbreaks of waterborne disease, including hepatitis E. The image you see here is an image of the hepatitis E isolation ward in the Batil refugee camp. Now, hepatitis E is a vicious waterborne disease for which there is no cure. All we can do medically is offer supportive care. In the general population in these camps, the crew fatality rate, the CFR, associated with hepatitis E was around 2%. However, for pregnant women in their second or third trimester, that CFR jumped to 20% for reasons we don't understand. What this meant was that oftentimes when we had one case come in, it often meant, unfortunately, 2 deaths because the child would either pass away in utero or be delivered so prematurely they had very little chance for survival. Now, this was incredibly difficult for all the MSF team to witness, and it firmed our resolve to beat back the outbreak in the camp by preventing its spread throughout the community. As a waterborne disease, to do this, we had to improve water, sanitation, hygiene services in the camps. Now, one of the things we worked on at this time was improving water supply and water safety in the camps. To do this, we are guided by core humanitarian standards on how to chlorinate water to make sure it's disinfected and then have some residual protection to keep it safe. The core humanitarian guidelines like the Sphere Project Guidelines or MSF's Public Health Engineering Manual or others all generally say the same thing when it comes to chlorination. The free residual chlorine, or FRC for short, at water distribution points should be between 0.2 and 0.5 milligrams per liter under normal conditions, or increase to 0.5 to 1 milligram per liter when pH or turbidity of the water are elevated. In South Sudan, even when we achieved these targets at water distribution points, when we went to refugee shelters where they were actually drinking the water and tested it there, we often found it had no detectable residual chlorine protection. In fact, there was also evidence that water in people's shelters was being fecally contaminated, all in the midst of a major waterborne disease outbreak. Super concerning for us. As we started to do some digging on these guidelines, we discovered that these FRC standards were not actually based on any field evidence from humanitarian settings. Instead, they were taken from the WHO guidelines for drinking water quality, which are meant for municipal pipe water systems in cities. Of course, in a city, we drink water directly from the tap in a relatively hygienic setting. In a refugee and IDP camp, people have to collect water from public distribution points called tap stands, carry it through the camp up to half a kilometer, and then store and use the water in their tent, in their shelter, for up to 24 hours or sometimes longer, all in settings where hygiene may be poor in the environment. So there are plenty of opportunities for recontamination to occur after it is collected. Now, as we dug into it, we found there are many reports, in fact, of water being recontaminated after distribution, leading to the spread of waterborne illnesses among displaced populations. We presented our concerns about the humanitarian FRC guidelines as we observed in South Sudan in a paper in the Bulletin of the World Health Organization. Now, as we looked at this problem, which we realized was probably affecting water safety in refugee and IDP camps all over the world, we started to have an idea. Humanitarian agencies are regularly collecting water quality monitoring data in refugee and IDP camps all the time, primarily FRC data as it's a proxy for water safety. Now, mostly this data just gets used for reporting purposes, but there's potentially life-preserving information inside of that monitoring data on how residual chlorine behaves after distribution. If we could better understand this, then we could figure out how much FRC we would need to have at the tap stand at the point of distribution in order to ensure there's enough residual protection at the household point of consumption many hours later. If we could develop analytics to help unlock this information, we could put them up on the cloud, and field workers anywhere in the world could simply upload their FRC monitoring data and use it to generate a site-specific and evidence-based FRC target for their specific site that helps ensure water remains chlorinated for the entire duration of household storage and use at that site. We call this the Safe Water Optimization Tool, or the SWOT for short. Let me zoom in on the analytics we've developed for the SWOT really quickly. We've developed two ways of analyzing FRC monitoring data to figure out how much FRC we need to have at tap stands in order to ensure adequate household protection. The first is an approach based on the numerical modeling of chlorine decay, and the second is an approach based on artificial neural networks. In the numerical modeling approach, we use a general integrated rate law to create an overall empirical representation of post-distribution chlorine decay using paired FRC and time data from tap stands and households. Modeling post-distribution chlorine decay as a function of time allows us to design FRC targets for tap stands that can protect water for different lengths of time depending on the specific situation at each camp. Now, we present this method and demonstrate its application in refugee camps in South Sudan, Jordan, and Rwanda in a forthcoming paper that's just in minor revisions now, and we hope it'll be out in the next month or two. The other analytical engine in the SWOT uses artificial neural networks, or ANNs. ANNs are a type of supervised learning algorithm for machine learning that mimic the structure of a neuron, which is the image here at the top of the screen, in which a set of inputs are mapped to a set of outputs. The analogous situation in an ANN is in the image below. Once trained on real-world data, an ANN can then be used to predict what the output will be when presented with certain inputs. Now, the advantage of ANNs lies in their data-driven nature. This means we don't need to have a prior physical relationship to link the upstream and the downstream, in our case, tap stand FRC to household FRC, as we do with the numerical modeling approach. This allows us to easily look at different kinds of data and include it in our models beyond just FRC and time, including data from other kind of water quality parameters, water handling behaviors, environmental and contextual data, wherever there may be a signal linking the input to the output. Currently, we've developed models that use as inputs tap stand FRC, water temperature, and electric conductivity, and we continue to evaluate other variables through input variable selection methods from machine learning. The development of the SWOT ANN analytics and its application in multiple refugee camp water system data sets is described in a paper just submitted by my graduate student, Michael DeSanti, that we hope will also be out in some months. Now, after we built out the SWOT and created a prototype, in 2019, we set out to evaluate how well it works for ensuring household water safety compared to the status quo sphere guidelines. We did this through a proof of concept study at the Kutupalong Bolakali refugee site in Bangladesh that hosts Rohingya refugees. At Kutupalong, MSF was carrying out medical and water sanitation activities, including operating water systems in multiple parts of the camp. We selected Camp 1 in the northwest sector of the camp, where MSF operated a water supply system that was serving 83,000 people for the SWOT pilot implementation. Now, across the 10 water subnetworks in Camp 1, we measured 3 water quality parameters directly from water leaving the tap at tap stands, including FRC, water temperature, and electrical conductivity. Once users have collected water into their containers at the tap stand, we accompany them back to their household and mark their container of water there. We then returned to that same household 4 to 18 hours later and measured FRC again from the same container. Now, between July and December, we collected over 2,000 paired observations following this protocol. We used data from the first half, July, September, to train the SWOT's analytical models and generate a site-specific FRC target. We then used the data from the latter half, October to December, to evaluate how effective the SWOT target was compared to the sphere status quo target using one. We also conducted a rapid knowledge, attitudes, and practice, or CAP survey to gather contextual data, including importantly, the maximum length of time that water is stored and used in households at this site. Now, from the CAP survey, we learned that the maximum length of time water is typically stored and used at this site is around 15 hours. So we took the FRC monitoring data, put it into the SWOT, and the SWOT generated a recommendation that the FRC at tap stand should be 0.8 to 1 milligram per liter in order to have 0.2 milligrams per liter FRC, a designation of what constitutes safe water for us, at 15 hours later. Now, we compared the SWOT recommendation to the status quo sphere FRC target using a chi-square test with respect to household water safety at follow-up, which showed a statistically significant relationship. Top line finding for us was that in Bangladesh, the SWOT recommendation would nearly double the proportion of households having safe water at 15 hours post-distribution compared to the status quo sphere guideline at that site. Now, in addition to the Bangladesh pilot, we've also been carrying out 2 remote user trials with MSF in Nigeria and with UNHCR in Tanzania in order to improve the usability of the tool. With user feedback, we've been refining the prototype over the past 6 months or so. And now the SWOT version 1 final tool is ready to launch to the public, and we're launching it on November 4th. You can check out the link above to request a user account if you'd like to try it out, and subscribe to our Twitter for project updates. Our next steps are to diversify applications of our safe water analytics to other use cases in non-emergency, more development-oriented settings, including in household water treatment programs, in intermittent water systems, in inline and bucket chlorination programs, and others. We also want to develop in the next year rapid protocols for evaluating chlorine taste and odor rejection thresholds and disinfection byproducts, both of which constitute important upper limits for chlorination practice. Now, taken together, these tools form part of an integrated SWOT toolkit that can help advance effective and acceptable safe water practices in humanitarian operations. So thank you very much for your attention. To learn more about the SWOT, check out the link above. Our team is standing by to support field implementers on using the SWOT in their projects. We have a number of people we want to thank without whom this work would not have been possible. We want to thank the Acmea Foundation and Grand Challenges Canada for supporting this work. We also want to thank the HQ and field teams at MSF Operational Center Amsterdam, as well as the field teams in UNHCR, NRC and BRAC in Nigeria, Tanzania, and Bangladesh for their amazing field work implementation on site. So thank you very much, and I look forward to your questions.
Thank you so much. Let's give Dr. Ali a virtual round of applause. That was fantastic.
Thank you.
I want to remind all participants to write their questions into the Pathable chat, and I'll go ahead and ask a few right now that have come in. This is from Rebecca Janoti. Are there any in situ FRC sensors that could further expand the use of this tool by providing a real-time water quality data, which could also free up HR time by removing the need for manual testing?
Yeah, definitely. That's a great question. There are some devices available on the market now. They also integrate with Internet of Things platforms. So UNHCR and MSF are both doing work on integrating remote data acquisition with Internet of Things for water supply, including on water quality. And we hope to work with the teams in MSF. It's actually in Bangladesh at the same sites that we had done the work previously. They're doing this IoT stuff for water quality and water supply. So we're looking forward to developing integration of the SWOT analytics with data acquisition in IoT, water supply with MSF and with UNHCR hopefully as well.
Thank you. This is from Megan Lindmark, related to the question above. Have you considered measuring other parameters in real time, like pH, oxidation reduction, potential, etc.?
Yeah, definitely. When we started out the research, we were looking at a huge suite of water quality parameters, including pH, turbidity, oxidation reduction potential. We were using handheld devices in the field in the early phases of the research to gather that data. If you've done ORP, you know it can be quite unstable, so it's hard to collect in field settings in a refugee camp next to a water, tap stand and whatnot. So we eventually stopped collecting that data because we saw that the most important data for us was FRC and time. Now with the ANNs, we can integrate other kinds of data to get a signal. So far, we've seen that there's some signal we can get out of water temperature, conductivity, and some other parameters. pH, not so much because of the range of pH tends to be pretty narrow. We don't see a lot of variation within a camp about it. So we're looking at other water quality parameters, but also other contextual factors and water handling behaviors as additional informational inputs that we can try to leverage through the ANNs.
Thank you. Another question from Musa Abba Mohammed. We did some internal experimentations and field checks and saw surprising results in the field. So what's up with water tracking, and what's up too with aqua tabs and the likes, which are distributed at the household level?
Yeah, so I mean, right now there's not a huge emphasis on water quality at the point of consumption, and that affects, traditional refugee camp water systems to more ad hoc programs of aqua distribution or water trucking. We're looking at how we can integrate the SWOT analytics with water trucking. That's our next phase of the research, and we're also interested in looking at how it can be linked up to figure out appropriate dosing regimes for aquatabs and other household water treatment methods. Really, like there needs to be a wholesale shift in the humanitarian sector away from more process and technical outcomes like chlorination levels at tap stands to the household level where people consume the water, because that's where the public health impact of safe water is either made or lost. So we want to advocate in this tool as a way to help shift focus to the household water consumption.
Last question for you from Natalie Exum. Can you comment on the feasibility of achieving the recommended FRC levels from the SWOT in these settings?
Yeah, so we see variability in our applications. It depends on how, on the complexity of the overall water system. If you have a lot of water sources, water storage, a lot of mixing networks, it's very hard to manage chlorination in that system, whether you have a good target or not. In systems that are more organized, more planned, it's much easier. It also depends on the team's level of experience and comfort in managing the chlorination levels. So there are certain things that we can control and we can't control, and we try to work with teams to help shift, where we can help them improve their operations. But sometimes, particularly in acute emergency situations where you have very chaotic water systems, it's very hard to actually improve the chlorination levels in those systems.
Thank you so much. At this
My
time,
pleasure.
I'm going to introduce our second speaker, second presenter, Dr. Drew Capone from UNC Chapel Hill, North Carolina, United States. You're welcome to share your screen now. I can see your slides.
All right, can you hear me?
I can hear you, great.
Let's see, from the beginning. All right, good afternoon, everyone. Thanks for joining. Thank you for the introduction. Yeah, my name is Drew Capone. I'm a postdoc at UNC, transitioning from Georgia Tech, working with Dr. Joe Brown. And this is our talk today on sanitation, titled Sanitation is Not Universal in the Urban US. And since you need a toilet to go to the bathroom when and where it's needed, we have the sanitation ladder, which I'm sure you're all familiar with here on the left, ranging from open defecation at the bottom to safely managed there on the top. And traditionally, because people need to go to the bathroom throughout the day, we've been thinking about access in terms of household access. And we've been measuring the sanitation ladder in terms of households. However, in the United States, at any given time, there's hundreds of thousands of people who are experiencing homelessness and don't live in homes and are being overlooked with the current approach in the sanitation ladder and the data that's being used. So what we have here is a figure where the x-axis is from 2007 to 2019, and the y-axis is the number of people experiencing homelessness. So the green triangles are people who were counted during the point in time count, which is an annual count in January, where people physically go out and count everyone they can find experiencing homelessness. And the green triangles are people in unsheltered locations. So those are places not considered suitable for human habitation, such as under overpasses or in cars. Gray squares are people in sheltered locations, such as in a homeless shelter or transitional housing. And the blue dots are the number of people overall. So what's important to take away from this is that in the last few years, we have been seeing an uptick in a large increase in the number of people experiencing homelessness, and in particular in unsheltered locations, which is primarily being driven by increasingly unaffordable housing and an increasing cost of living in US urban areas. Now, add in a global pandemic where there's been a huge economic shock to the system. There are tens of millions of people now at risk of being evicted. And when you are evicted, you not only lose your dignity of losing your home and the safety and comfort that comes with that, but as people in the WASH sector, if you lose your house, you're also losing consistent access to water, sanitation, and hygiene. And there have been some very good things that have been done so far in terms of an eviction moratorium in the US, and the CARES Act has allocated money for renters and landlords. But this work needs to be continued to ensure that millions of Americans stay in their homes, retain their dignity and their access to water and sanitation. Now, it's not surprising that if we have hundreds of thousands of people at any given time who are sleeping outside or in other unsheltered locations, that open defecation is in fact common in many US cities. Our work here on the left, where we actually characterized open defecation sites in Atlanta. I went around and documented all the open defecation stools that I could find. We characterized some of those sanitary risks. This work has led to some additional work with a colleague of mine, Dr. Liz Fry from the Street Medicine Institute, where we've continued to think about the numerous barriers, both physical, mental, that people experiencing homelessness face to accessing sanitation. And these barriers are so high that regardless of where you're living, if you're experiencing homelessness in an unsheltered location in the United States, accessing either a public toilet or a publicly accessible toilet is often very difficult, leading to open defecation, as you can see here in the figure in the top right. Now, water and sanitation may have been declared a human right in 2010 by the United Nations. However, the US was not a signatory on this resolution and has not adopted it. And in fact, over the past few years, as special rapporteurs to water, sanitation, and hygiene from the UN have visited the US, they have repeatedly mentioned that the conditions in which people experiencing homelessness are living are similar to, and oftentimes perhaps even worse than low-income informal settlements in low and middle-income countries. Now, it's not surprising then that when we have hundreds of thousands of people who are experiencing homelessness with poor access to sanitation and uncontained feces in the environment, that people experiencing homelessness have been linked with several disease outbreaks in the past few years. First, on the left, we can see here, this is some data and a figure from the US CDC. We've had a large hepatitis A virus outbreak in the US since late 2016, early 2017, that has been linked and has spread across the country, in part due to the transience and poor sanitary conditions of people experiencing homelessness. There's been tens of thousands of cases and hundreds of deaths associated with this outbreak. And then obviously we're in the middle of a global pandemic. And in a pandemic where suggestions have been to do things such as physically distance, wear masks, wash our hands, these can prove difficult, if not impossible, for people experiencing homelessness. In fact, this was a study done from a large homeless shelter in Boston earlier this year. And of the participants, over a third tested positive in this cross-sectional study for SARS-CoV-2. So this led us to think and ask the question, in terms of the sanitation ladder that we use to measure access and progress towards sanitation, how many people in the urban US do not have access to at least basic sanitation? Remembering that basic sanitation is the use of improved facilities such as sewer systems, septic tanks, or pit latrines with slabs which are not shared with other households. Now, so the first step was figuring out, how does the JMP currently produce their estimate? And I will note that the JMP gets their data from the US government. So it is the US government that has chosen to share American Housing Survey data with the WHO UNICEF JMP. The data that they're sharing, the AHS, is run by the US Census Bureau, and it predominantly focuses on the 15 largest US cities. The question that's asked in the survey is whether your household has a sewer connection, a septic tank, or some other kind of sanitation. Alternatively, we decided to use data from the American Community Survey. This is a more representative survey that actually has data from all 382 US metropolitan areas and not just the largest US cities. And they asked a question about the presence of a flush toilet in the home. However, for reasons I don't have to get time to get into today, this question is sadly no longer being asked by the ACS. Further, because both the AHS and ACS only survey households, we also wanted to include point in time count data, which is, as I mentioned, of people experiencing homelessness on a single day in January, which is taken each year. And we decided to classify people in unsheltered locations as open defecation because they do not have consistent access to a toilet or some type of sanitation facility. And those in sheltered locations as limited because they would be sharing sanitation with other folks in a homeless shelter or in transitional housing. Now, the results. So the figure here on the x-axis, you can see on the left is the current estimate from the JMP, and on the right is our new estimate using these alternative sources of data. And on the y-axis is the number of urban Americans. So currently, the WHO UNICEF JMP estimates that 28,000 people in the urban US lack access to at least basic sanitation. However, when we include point-in-time count data on homelessness, we estimate at least 460,000 urban Americans lack access to at least basic sanitation. And when we include ACS data on whether these households have a functioning flush toilet in the home, we estimate an additional 470,000 people live in homes without functioning flush toilets. So altogether, this suggests that at least 930,000 urban Americans lack access to at least basic sanitation. And some discussion on this. I think one of the big limitations with the data that we're working with is the question only asks about the presence of a flush toilet.
1 minute.
So it's entirely plausible that some of these households may have been using outhouses, which if safely covered does constitute safely managed sanitation, which could suggest our estimate, in fact, is an overestimate. However, the point-in-time count vastly underestimates homelessness. It excludes people who were in prison who were experiencing homelessness at the time of their incarceration, and it is cross-sectional, so it doesn't take into account everyone who may be experiencing homelessness throughout the year. Further, we only looked at access, but there are other important issues around treatment, such as failing septic tanks and combined sewer overflows in the United States that should be considered. And I hope this work and similar work leads us to begin asking questions and thinking carefully about who is being excluded by current survey methods. And perhaps approaches such as this might produce more inclusive estimates, which could allow for greater policy attention to this issue and hopefully put us on the path towards achieving SDG 6 in the United States and other high-income countries by 2030. So with that, I'll take any questions. Thanks.
Thank you so much, Dr. Capone. Let's give him a virtual round of applause. That was wonderful. I want to remind participants that if you have any questions, please do direct those to the Pathable chat in the Water and Health Conference website platform. I don't see any coming in at the moment. I will ask you one question of my own.
All right.
Was the census data that's provided to JMP, is that from back in the 1990s?
So AHS is taken each year. So yeah, the US Census is every 10 years and AHS is an annual survey. So that's fairly up to date.
Okay, great.
But the ACS data that I used for these estimates came from the 2017 5-year estimates.
From Ian Ross, asking, do you think there would be seasonality in pit count data? For example, more people on the streets in the summer?
Yeah, so that's a great point. And by taking this data in January, when there are some shelters that are only open during the winter, so we're actually probably underestimating people who may be in unsheltered locations in the summer, as well as warming shelters that open up in the winter, and there are other alternatives. So it certainly is an underestimate by doing it at the coldest point of the year. Yeah.
Ryan Sinclair, when did the ACS stop asking about flush toilets?
We got this data in 2017. So it was 2 or 3 years ago now they stopped asking about it. And that is because over 40% of people wouldn't even respond to, I think it was 43% was the exact figure from our work, because people feel it was somehow too invasive to be asking whether or not they had a flush toilet in the home. And there's been some push from certain politicians that we don't need to be asking about sanitation access on the ACS in 2020 or in this age.
Thanks. From Bethany Crusoe, a comment, thanks Drew, really highlights the importance of data quality and appropriate data sharing by those who create and curate it. And a question from Pippa Scott. Have you shared this data with any local authorities? If so, what is the reaction?
Yeah. So as an engineer, this is, I feel like, probably my biggest struggle is trying to communicate this data to local authorities. And I have reached out to Atlanta City Council. I've reached out to the mayor. I've reached out to several different folks. And I think the issue is I'm showing that there's a problem here in Atlanta, and it's easier to ignore problems than try to fix them. So I haven't really made any headway with trying to engage local officials, because I think they probably see me as someone that they just don't want to interact with because I have data that, and if they acknowledge that it's there, then it suggests they should do something about it. So that's kind of my interpretation of so far my attempts to reach out and begin discussing with Atlanta officials.
From Natalie Exum, nice work, Drew. Can you comment on the most likely sites of transmission in this population for the outbreaks you described?
Yeah, I think there's kind of the challenge is oftentimes when you have homeless camps, because you get so many people who aren't in a small area who aren't being served, like don't have basic services. So when we have homeless camps who don't have sanitation, they don't have water access, there's no hygiene, there's no trash pickup, then the risks for person-to-person transmission are quite high. And the uncontained feces in the environment with the camps that I've seen in Atlanta, kind of with my work with Dr. Liz Fry, is that folks are, I mean, we're going 50 meters from where the camp is to openly defecate. So there's a large amount of feces that's just uncontained in the environment. And obviously if you're openly defecating, you don't have the opportunity to wash your hands and take a shower, and you're not storing your food in a hygienic manner. So there's a lot of different potential transmission pathways for these pathogens in these camps.
And lastly, in 30 seconds, what are some solutions or services to reach the homeless communities? What can the government do? Do you have any examples?
Yeah, I love the program Housing First. We need to lower barriers for people to getting housing. People might have mental or physical issues, substance abuse issues. And if we can put people into housing, then we can get them access to water and sanitation.
Great, thank you. We're out of time, but I will direct you, Drew, to a few questions that came into the Pathable chat to respond to there.
Thanks.
And so I would like to invite our third speaker, Professor Kwabena Nyarko from Kwame Nkrumah University of Science and Technology in Kumasi, Ghana. If you could start sharing your slides, please.
Thank you. Can you hear me?
We can hear you and we can see your slides.
Okay, great. Good day. The presentation is on quantifying user experiences of sanitation, container-based sanitation in Ghana. My name is Kwabena Nyarko. I'm a professor in civil engineering in Kwame Nkrumah University of Science and Technology. My co-authors are, as shown here, James Tidwell, Ian Ross, Bessemark, Pippa Scott, and Charles Odro. The work is focused on evaluating customer satisfaction with container-based sanitation in Kumasi, and was commissioned by Water and Sanitation for the urban poor. Study was a longitudinal one where we interviewed customers before they got a service, that's the container-based sanitation, and 10 weeks after having the service. And we use both qualitative and quantitative measures. The focus, as earlier on indicated, is on customer satisfaction, and the results show the increased customer satisfaction in almost all the domain areas. And findings suggest that policymakers can in fact consider other factors such as safety, less disgust, less shame, better privacy to improve sanitation demand and uptake of services. We also realize that monitoring and evaluation of outcomes beyond health could demonstrate a broader impact of improved sanitation. So this is what we worked on. To give you a background of the study, sanitation is a problem in Ghana. where access to safely managed services is around 20%. And in the dense, low-income urban settlements, affordable and acceptable sanitation is a problem. Usually sewers are not available and on-site systems do pose problems, especially when we have high water table, etc. And container-based sanitation has come up as a possible solution. And they refer to a sealed cartridge installed in a freestanding toilet that is regularly removed and adequately separates users from their excreta. And it's also recognized by JMP as improved sanitation. Some work has been done on container-based sanitation, but the focus was on business models and cost. In the area of user experiences, we don't know a lot about it. So that was the main reason why we decided to focus on this topic. And our focus was with respect to quality of service and quality of life. And we use Clean Team because they've been in Kumasi for over 7 years and they have been providing service all this period, and it gives good basis for comparison. The research method used was a longitudinal prospective cohort study of new Clean Team customers. What we decided to do was we enrolled 404 potential customers at baseline. And after the 10 weeks, we had 292 completing the survey. What happened in between was that 17% dropped out at the subscription stage. That means they did not take the service. 2%, we could not get them because they were not available at the time of survey. And 9% declined after subscribing, they declined to install for a number of reasons, space, relocation, etc. And what we measured relates to service quality, that's the product failure, frequency and regularity of the pickups. We also looked at sanitation quality, cleanliness, accessibility, customer satisfaction, comfort, etc. And then we looked at user sanitation related quality of life, SANQUAL, on 5 attributes: disgust, health, privacy, shame, and safety. This is what we looked out for. Who are the Clean Team users, their profile? Median age was 44. With respect to employment, majority were self-employed. Average monthly rent was around $12 a month. And in terms of the users, residence time tenants on average had been there for 6 years and landlords about 17 years. With respect to housing, majority lived in a single room. That's a family is based in a single room, 70% and 22% in 2 rooms. Main household size was 3. Number of households in a house was 7. In terms of previous toilet location, for both the renters and the owners or landlords, we realized that almost 70%, their previous toilet was located outside their house, outside their compound. In fact, only a few, less than 3%, have toilet in their own dwelling. So this is the users we're looking at. Results with respect to customer satisfaction based on the sanitation related quality of life, where we looked at privacy, health, disgust, safety, and then avoiding shame. We realized that there was an increase in all the attributes. Higher scores means better satisfaction. So we realized that in all the areas, there was an improvement, and the largest single improvement was with respect to shame. That means customers were happy to have a sanitation facility in their dwelling. And when we look at the overall increase, that's on the Sanitation Quality of Life Index, the increase was 30%. And in analyzing this, the weights that were used were based on interim study from Mozambique, and we are yet to finalize that for the Clean Team study. When we look at cost, we realize that 44% prior to having the Clean Team service indicate they were satisfied with the cost related to sanitation. But once they had a Clean Team service, the number increased from 44% to 86%. We also saw an increase of those who worried about cost of sanitation, increasing from 17% to 30%. And we believe this is for households with small household size. Maybe there's only one person or one or two. That means the unit cost for using the Clean Team container-based sanitation will be relatively high compared to, let's say, household size of 5. So that is what we found with respect to cost. With respect to gender, we looked at menstrual hygiene management. We also looked at balancing household duties and toilet use. And in both cases, there was a big improvement. For example, if we consider those who were satisfied or very satisfied, it moved from a little over 20% to over 90% for those practicing menstrual hygiene management, and a similar increase for ability to balance household duties and toilet use. We also decided to look at some other indicators: privacy, cleanliness, safety. And then we also realized that even though generally there was an improvement, the increase for females, that is the pink line, for females were much higher than for the males. We also looked at the service quality, and it was also very good. Big improvement related to smell, maybe 2 or 3% had issues with smell. And the container replacement, more than 96% as was planned, which was very good. And when we look at ability to use toilet at night, there was improvement from 33% to 98%, which was good. And exclusion due to physical or disability, it reduced from 5% to 0.4%. So in a nutshell, customers were highly satisfied, especially when you compare to the previous toilet experience, which was related to public toilets. And there was substantial improvement, particularly for women and girls and those with disabilities. And perceptions of safety, privacy, disgust are important demand-side drivers for sanitation improvement. And sanitation-related quality of life is an approach to allow us to do that. We also think that policymakers need to consider sanitation outcomes beyond health in order to improve sanitation demand and then also uptake of services, and including quality of life indicators in monitoring and evaluating performance of sanitation is valuable in demonstrating the broader impact of improved sanitation. I would like to acknowledge UK Aid, Water and Sanitation for the Urban Poor, for supporting and funding the project, and also like to say a big thank you to Clean Team for their cooperation, as well as the municipalities that we interacted with. On this note, I'll say thank you, and then we are open for questions. And this is the evaluation team. Thank you.
Thank you so much, Professor Nyarko. Let's give him a virtual round of applause. I have a few questions coming in for you. The first is from Eduardo Perez. The increase in happiness with the cost of sanitation is surprising. Any thoughts as to why they are happy? Are the costs cheaper now than before? What about the costs and how does that compare to the rental costs for the renters?
Thank you very much. Average rental cost was 68 cedis a month. Those using public toilets, the median cost was also around 45 cedis a month. That is based on household size of 3.1, and 1/3 are children less than 5 years. So when using public, one, they don't use public toilets and they don't pay. And frequency for using public toilet is 1.5 times. So at the end of the month, it comes to almost 45 cedis. Remember, rent is 68 cedis. For clean team, rental fee or the cost of the clean team facility is 43 cedis. So if you look at that for the average, in terms of cost, it's almost the same. But those with household size more than 3 will pay less. And those with household size less than 3 will pay more. But in terms of the benefits, that is what was presented. So in terms of cost, this is the cost numbers. Depending on the household size, that determines whether you pay more than a clean team service or you pay less.
Do you have any thoughts as to why the happiness increased with the cost of sanitation?
The happiness increasing, we said those who are satisfied with the cost increase. And remember, some were paying more than clean team service. And if we take the sanitation related quality of life, we have privacy, ability to use the facility at night. We have avoidance of shame. There are many factors. So I think the sanitation related quality of life explains it, why people like the clean team service. That's the container-based sanitation. And it also looks nice.
Thank you. This is a question from Caitlin Rakish. Why did 17% drop out or decline to participate at the subscription stage? Do you have any thoughts there?
Okay. It has to do with the methodology. We wanted to recruit just before installation. So we had to work with clean team, but ensuring that we were independent. So we got a list from them of those that they have approached, but had not yet closed the deal. So we said, in order for us to carry out the research, you give us a list, we enroll them, and then we think majority will definitely take the service. So we work with the marketing team. They hadn't yet closed the deal, but we thought we needed to get that list to enable us complete the research.
Thank you. I have one more question for you from Chuck Fisher. For Professor Nyarko, given your results, we should employ CBS in urban areas everywhere. Are the circumstances in this location in Ghana that culturally or otherwise would inhibit broad expansion?
Okay. I wouldn't say we should use it everywhere, but I'll say it is one of the options. There are areas where the other technologies do not work. And in such circumstances, CBS should be considered. And we haven't seen any cultural issues that goes against it. In fact, some of the areas we have Muslim brothers and sisters, they use it, even though they practice ablution, it works well with them. And it clearly addresses challenges related to on-site sanitation in densely areas where we have the urban settlements, low-income urban settlements, yes.
Thank you, Professor Nyarko. We are out of time for our presentations today. Thank you to all of the participants, and especially thank you to our 3 verbal presenters today. I will now be ending our session. Enjoy the rest of your afternoons, days, mornings, and evenings.